you. I see most of my colleagues here. Thank you for coming. So I'll be presenting principles of back pain management with physiotherapy. With the principles, we have the acute inflammatory stage, subacute, and the chronic stage. With the acute inflammatory stage, the patient usually experiences constant pain, and there are signs of inflammation. No position or movement completely resolves their symptoms. Activities of daily living are acutely affected. And like the doctor said, medical intervention with anti-inflammatory medication is usually warranted. Subacute, usually at this stage, pain is provoked with certain movements and postures with some instrumental ADLs. Lifting, gardening, and other activities requiring repetitive movements of load. A basic lifestyle cannot be fully resumed. Chronic stage, emphasis is placed on returning the patient to the high-level demand activities that will require handling repetitive loads on a sustained basis over a prolonged period of time. Our goals for physiotherapy management, similar to what you have, it's reduction of pain, improving function, reintegration to society, work, sports, social activities, prevention of recurrence, so loss of education there, promoting self-management and self-awareness. That's more in the chronic phase, and that's where the push is for chronic pain, but I'll discuss that later on. Management guidelines for physios. So in the acute phase, like I said before, we decrease acute symptoms. We can use some of the price principles, your protection, ice, compression, elevation. We use manual therapy, we use exercise therapy, and we educate the patient. So we educate them on the condition that they have. What is it? Is it a muscle spasm? Is it a joint? Is it a disc? We show them diagrams and all, and then explain what is expected. Is it a long-term thing? Is it a short-term thing? We demonstrate safe postures. Control of stabilizing muscles, very important, whether in the acute, subacute, or chronic phase. And then we teach awareness, teach safe performances of basic ADLs, activities of daily living. So like your gardening, we'll teach the patient how to do gardening, how to bend down. For example, using their knees, not their back, to bend down. So you use your knees and your hips to bend down and pick up something or work on the garden, other than bending your back, because these muscles are very strong for that, unlike your back muscles. The doctor's already spoken that 20% of the weight is distributed on the back of the spine. So bending, forward flexion, picking up heavy things, that puts a lot of strain on your muscles. So rather use your knees, your hips, muscles to pick up heavy things. So that's part of education. In the subacute phase, we still do manual therapy, but 50% manual therapy, your exercises, your massage, soft tissue, joint mobilization, but we still focus on the exercises, self-care, teach healthy habits for self-maintenance, teach safe progression to high-intensity level, high-intensity activities, increase. Now we can even bring in cardiopulmonary endurance. In the chronic phase, still go on to educate, but in the chronic phase for physios, we more on exercises, self-awareness, teach techniques of stress relief, increase mobility in tight muscles, joint or fascia, teach safe body mechanics, functional adaptations. And then the modalities that we usually use as physios, it's your cryotherapy, your ice, more in the acute phase, your heat, more in the subacute or chronic phase, exercise therapy. We start with exercises from the acute to the chronic phase. Immobilization, bracing, stripping, although there isn't a lot of evidence on bracing, but we do use it. But strapping, kinesio tape is part of it. Passive joint mobilization, active joint mobilization, muscle energy techniques, ergonomics, and lastly, cognitive behavioral therapy. And this is where the science is showing us where evidence is going, especially for chronic pain. I'll speak more about that. So current trends for chronic pain that we have now, it's your artificial intelligence, so using of devices, using computational algorithms to organize or predict or influence future behaviors and outcomes. So this data that we gather from AI, you can use it to organize or predict, future behaviors from the physiological data that you receive. And then I spoke about cognitive behavioral therapy. This is more in the chronic phase, and there's well-documented evidence for this. So things like distraction, pain, patients that are always complaining have been having pain for more than a year, 2 years, 3 years. The doctors have tried this, the surgeons have done this, but still they're still complaining of pain. So cognitive behavior, there are physios who have studied these therapies, but if you have not as a physio, you would refer to your clinical psychologist. They use distraction, neural reprocessing, mindfulness training. And mindfulness training is, for me personally, it's what I prefer, because it teaches the patient to be more aware of their thoughts, actions, and to respond to challenges with resilience. Lastly, the third trend is the wearable medical devices, such as virtual reality. So with this, one can track a wide variety of factors, ranging from vitals to complex physiological signals that may have a profound impact on patients' pain as well as function. And then one of the virtual reality devices that they use, it's these goggles that they put on. Patient with pain, they're always complaining of pain. They can't do this, they can't do anything. You give them the goggles, they play maybe a video game. You ask them what's their favorite sport. They put that, they play a video game while on the virtual reality. And the benefits of that has been shown to improve function over the months. And then the funding trends. I think I'm still on my 50th slide, so we have 50 slides to go. Is that okay? The funding trends for chronic pain and back pain. So we know we are in a world where finance is very restricted, funding is very restricted. Medical aid get depleted quicker than what we can provide. So what's happening now is that some of the main funders like GEMS, MedScheme, Discovery, BestMed, they have these programs for chronic back and neck rehabilitation. Some of them are called DBC, Documented Based Care. And they offer patients back and neck rehabilitation programs to provide them and their registered dependents with appropriate treatment to manage back and neck pain. And this is outside the patient's savings day to day. Then we've seen positive outcomes that includes improved flexibility as well as reduced pain and stiffness, leading to a more productive life. And it's evidence-based program. I think that will be my last slide. Thank you. Mary Jane. Yes, doctor.
How do these people use? How do they then you put them under their or some kind of support then supporting the spine? What do they do? How do they do that? They call them bulletproofs. I got a bulletproof.
So from my experience, from my side, They are very important, but mostly post-op. So if a patient has done a procedure like a laminectomy, so very important to have that, but it's only for a limited time. But some patients, they don't receive physio, so they don't get to strengthen their stabilizers. So that thing is holding them. It's giving them comfort. So they end up using it. Yeah.
So
Can you please add, yes?
I'm going to choose my words very well because we are in the presence of orthotics. So, yes, I'll choose my words very wisely. It is right. So the problem is that with bracing and chronic back pain or acute back pain, especially acute back pain, it makes the muscles lazy. And the most important thing in the early inflammatory stage is what he was presenting. And as soon as they go a day 2 or 2, they need to start building up their muscles. If you put them on the brace, it's just like if you put someone on a cast for 6 weeks. What happens when you remove the cast? The muscles are thin.
They're wasted.
So you want to prevent that on the early stage. On the chronic stages of back pain, you can use it in one particular circumstance that I presented to say if you have had discogenic back pain and now you have instability. Now the problem is that in the bodily stasis, if you don't support them and you send them to him to do physio, they are not going to cooperate anyway. And it's usually the
It's a safe space.
It's usually the large females who have this problem, right? And I'm telling you, they always come back and say, physio is too painful. So those are the ones that you want to give them medication and you want to maybe give them steroid injection and give them that brace for a certain period. And then from there they can go to physio. But the most important thing is going to be them building up their own muscles. Post-op, definitely.
Yeah. Yeah.
Always.
Yeah.
And sometimes.
And before you examine them, they just take it out.
on patients with fractures, osteoporotic fractures, right? If you're not going to avoid putting them because they are at risk of kyphotic deformity. So they've got osteoporotic fractures or post-traumatic, but the fracture was not too severe to warrant surgery. In the early stages where the bones are still healing, which is 6 to 12 weeks, we can give them that to support their posture so that they're in the upright position. Because when we're painful, we tend to want to be in this position, and that worsens the kyphotic deformity.